Good evening, everyone. It's really great to be here. Thank you so much for coming. We're going to get started. So it's really a pleasure to welcome everyone here after 3 years. It's been quite a 3 years, I would say. And so we're really glad to be back in person. I'm Josh Meyer. I am a radiation oncologist here and Vice Chair of Translational Research in the Department of Radiation Oncology. I really am grateful to be sharing this evening with you. We're going to have a pretty simple format tonight. So first we have a really great panel, and actually a really nice sized panel with everyone representing different aspects of the fight against pancreatic cancer. So we're going to go through and introduce ourselves and talk a little bit about what we do here. But we're going to try to leave a lot of time for questions from the audience after we're done. So first, I'd like to take a moment to honor all those we've lost to cancer. So please join me in a moment of silence. Thank you. I'd also like to thank our exhibitors for their support this evening. It's really because of them that we can offer this program to our patients for free. So our gold exhibitors tonight are AstraZeneca, Caris, Exact Sciences, Foundation Medicine, Guardant, Lilly, Natera, and Tempus. Our silver, Our silver exhibitors are AbbVie, Boston Gene, and Insight. And thank you also to these advocacy organizations for their participation: Pancreatic Cancer Action Network and Pancreatic Cancer Cure Foundation. So I'll remind you, you have cards out on your tables, and you can write down questions for us on those cards, or you can simply raise your hand and ask us questions when we're done with the presentation. And with that, I think we're going to start our introductions. So the first person I'll call on is the way we always start these events, because of the critical importance of surgery in pancreatic cancer. So I'm going to call on Dr. Sanjay Reddy to tell you a little bit about who he is and what he does here in the fight against pancreatic cancer.
Thanks, Josh. Good evening, everyone. I put together a few words, but I think I'm going to go off script a little bit for two reasons. One is my role as a surgical oncologist is one that sort of comes in and out, right? This disease, we've learned a long time ago, is not one that will be dealt with by a single person or a single field. It's chemotherapy, radiation, surgery, and that combination. And I think the idea of multidisciplinary care here at the center really sort of highlights this panel out here today or tonight. And you'll hear sort of individual sort of tweaks about the chemotherapy and radiation aspects of things, but ultimately it does culminate into surgery, and I think that's what everybody hopes to sort of shoot for. And how we get to that point is still nebulous at times. We've at the center, one of our most impactful things that I think I can tell everybody here today is we've been a center that really embraced this idea of total neoadjuvant therapy, right, where we use a combination of treatments, chemotherapy, radiation, and surgery to render responses and provide good life to patients. This is something that's been pioneered here from the beginning, and I now have to blow up his spot. Dr. Hoffman is in the house. Round of applause. He has been my mentor. I learned everything from him. I do everything the same way he does them in the OR. I teach all my fellows the exact same things that he does. And I see a lot of my patients out there who are here, and it's because of him. So thank you, Dr. Hoffman. But the idea that he started 30 years ago has sort of come into mainstream now. And, you know, I think that in this current healthcare climate, there's a lot of notable people with diagnosis of pancreatic cancer, right? Congressman Lewis, Ruth Bader Ginsburg, Alex Trebek, and it's really sort of highlighted to the community and the world that this disease affects all walks of life. And the things that we're doing here at the center through the Greenberg Institute and through the efforts of all my colleagues here really help move that needle. And it moves in small increments, and that's hard for some people to sort of swallow and see, but it's moving. And I'll just lastly say you have to have hope. That's sort of the motto of PanCan is wage hope. And it's through events like this and outreach to you that I think we make progress. So thanks.
Thank you very much, Dr. Reddy. Now I'm going to move to Dr. Dotan to introduce herself and tell you a little bit about what she does.
Hi, everyone. My name is Afrat Dotan. I'm a medical oncologist here, and I treat GI malignancies and specifically pancreatic cancer. So I think as a medical oncologist here, our job is to obviously take care of patients, help with chemotherapy, whether it's in the setting of giving chemotherapy before surgery or in the setting where surgery is not an option. But in addition, our job is really to think about clinical trials, bring clinical trials that are innovative, new, exciting, and bring new treatment options to patients, and figure out how we can get as many patients as we can on these trials so we can really advance the field forward. So that's a big part of what I do here in terms of trying to find studies, getting them through our system, activating them, getting patients to enroll on them, and ultimately analyzing the results when we have enough patients. I think pancreatic cancer is really at a stage where there is a lot of excitement about clinical trials and new drug development. There are new studies that are coming out all the time, and the only way to really move the field forward is really to support these efforts. And it's only because of very, very brave patients that have participated in trials in the past that today we have all this data to share with patients and various treatment options to provide.
Thank you, Dr. Goodman. So next, I'll tell you a little bit about what we're thinking about these days in terms of radiation. So my main job is not as an MC. I do this very rarely, but usually I'm treating patients with radiation, and particularly pancreatic cancer patients. I treat many. And we can use radiation in a variety of ways, and like Dr. Dotan alluded to, these ways are changing because we run clinical trials, because we look at our treatment patterns and continue to refine what we're doing. So we're able to bring new treatments into clinic, and I think we have one trial that's currently up and running for pancreatic cancer patients with a new technique of radiation that we're very excited about. We're writing another trial to look at a different new technique of radiation currently. We sometimes use radiation to treat patients who have cancer that is going to be operated on. We sometimes use radiation to treat patients who can't get an operation, and so we're doing things a little differently in that context. And then we occasionally use radiation to treat patients who are just symptomatic. They have pain, say, and we're trying to help them with their pain. So we have lots of different opportunities to help people, and I think, you know, the thing that Dr. Reddy led off with is absolutely true. You know, what makes this place so great is we're a real team. We work together, and we work together with patients to try to make sure that we can find the best possible treatment for people and the best way to support people. And I think you really feel that here. It's a different kind of a feeling than you might get somewhere else. So it's always a pleasure for me to work with this wonderful group of people here, and to get to care for patients like some of you, and to do everything we can to give you the best possible quality of life and to extend lives as long as possible. That's really why we do it. So I always look forward to coming into work and really taking this on because it's very meaningful to me. So with that, I will say we should move on to Dr. Ostaturov, who's sitting close to me, and he's going to tell you a little bit about some of the things he does here that make his contributions special.
Thank you, Josh. Hello, everybody. Igor Asaturov. I'm a medical oncologist during the day and research scientist at night, and for the rest of the time, waking hours. My role, as I see it in this great team, is to really take a maybe more deep mechanistic dive into pancreatic cancer biology. And I'm very privileged to collaborate with my clinical colleagues, with Dr. Kuckerman, Eti Kuckerman, who will speak for herself about her great work that she's doing in her laboratory. But we're trying to understand what makes pancreatic cancer more aggressive. And once we get some ideas, we also very eager to translate these ideas to the clinic. And we are blessed with good collaborations with Dr. Dotan, Meyer, Reddy, Dr. Hall, and a great team of population science. So I'll stop here, but if you have any particular question related to why the pancreatic cancer arises, what drives it, what makes it so difficult, please, I'll be happy to answer.
I think now we're going to go down toward the end of the table here, and we have Jalen Kellogg here, who's going to tell you a little bit about what she does with pancreatic cancer patients here at Fox Chase.
Hi everyone, my name's Jalen Kellogg. I am a dietitian here. I primarily specialize in nutrition support, so the majority of the patients that I see either have a feeding tube or are on what's called TPN, or a form of IV nutrition. However, our team as a whole, we do see all patients with pancreatic cancer, and that's mainly because this type of cancer does have a lot of nutritional implications, whether or not this is related to treatments or just disease itself. We see a lot of patients who are suffering from weight loss, have a lot of nausea, vomiting, or other GI distress from treatment or cancer itself. So we kind of just help to guide patients with different foods that may help alleviate symptoms. But what we want to stress that's most important is mainly just maintaining weight and trying to follow the least restrictive diet to help the patient do so. So we really recommend just following, like eating a well-balanced diet, focusing on protein foods to keep your muscle mass and your strength up, especially to get you through treatment feeling strong. So we do offer outpatient counseling as well, and which is available to everyone as a Fox Chase patient.
Thank you very much. Next, I'd like to call on Dr. Hall to tell us a little bit about what he does that's special, because you are sitting at a table with two other medical oncologists, but you have other qualities that we appreciate you for.
I thought you were going to say because he is special as well, which I like to think I'm special. But, so I'm also a GI medical oncologist like Dr. Dotan and Dr. Asaturov. One of the most common questions I think I get from my patients is why did I get this? Why, of all the things, I lived a good life and I exercised, I didn't drink too much. Why did I get this? The second question is often, how can I protect my family members from getting this? And then a third question is often, why, when I watch the news, why is pancreas cancer going up? I thought you guys were working on this. It should be going down, but yet when you look at the news, it's moving up into the fourth most common, cancer in adults. I'm going to let my colleague, Dr. Lynch, who's much more of an epidemiologist than me, comment on the last question. But rates are going up. But I can actually help comment on those first two questions. And I think we have learned an enormous amount just in the time I've been practicing to understand why people develop pancreas cancer, whether it be due to risk factors in the environment or behavioral risk factors, or genetics, which is, of course, as many of the people in the room know, I'm super happy to see several of my patients here tonight. But genetics has really helped us understand a sizable chunk of why people get pancreas cancer, and the value of that is not just purely intellectual, that we can say, oh, now we know, but that we can actually use the genetics to understand why other people in the population who may have the same genetic risks might be at risk, and what we can actually do to help those people avoid a diagnosis of pancreas cancer. So it's all about prevention. There are some wonderful studies going on in this country and around the world offering screening to patients who are at higher risk of pancreas cancer due to genetics, and they're actually, showing benefit in their earliest phases. Now, this is still going to be always a tough disease to beat, but I think the research is moving in the right way. I do think there is some bright lights in the future, and it's really all about the people in this room who have contributed to research, have joined some of our research studies, and who come to events like this and spread the word to others out there that really help us move the field forward. So thanks to everyone for coming tonight.
Thank you, Dr. Hall. Next, I'd like to call on Anjali Albanese to introduce herself and tell you a little bit about what she does here.
Thanks, Dr. Meyer, and thank you to all of you for joining us this evening. As you've heard from the panel of experts that have spoken before me, we really do take a team approach to care here. I know Dr. Meyer mentioned that as well, and we take a lot of pride in that. My role specifically, at least how I see it, is to help you focus on the emotional and the mental impact of the diagnosis. We want you to recognize that we truly understand that this disease doesn't just affect you physically, although that tends to be the reason why people enter our front doors. But we want you to know that we see you as a whole person. You were a person before the cancer entered your world, and we want to help you get back to that, or we want to learn the things that are most important to you so that we can help support you through that process. We do that in a lot of different ways. For some people, coming to talk to us one-on-one tends to be the most comfortable option, so we want you to know that that's always available, whether it's in person, over the phone, or as the pandemic has taught us, that we can use Zoom as an option as well. We are here to help people figure out how to talk to their children about this illness. Oftentimes people will call and say, this is just what happened to me. How do I tell my children? So we're here to sort of guide you and walk you through that process as well. We do have a GI support group that we offer here. We are in the process of kind of revamping how we do things. We're going to take a more psychoeducational approach to that group, where we'll have an expert speak to you for the first half and then have a support group afterwards. And sometimes that's a nice opportunity to meet with other patients that are going through something similar. We also recognize that the disease can affect you in all aspects of your life, whether you are having to take time off from work, whether it's placing a financial burden on you. We have resources that we can help link you up to. If Fox Chase isn't close by, we can help you find community resources that are more local to you. And the thing I always want to end with is just to say that we're here to help you focus on the hope. And whether the hope is how do you get through the first day, how do you get through the first week, or how do you think ahead to the months and years ahead, we're here to support you through that process. We have brochures if anybody wants to know more about what we do, and they're on the table over there, so please feel free to help yourself. And please don't hesitate to reach out if there's anything that we can do to help. Thank you.
Thank you very much. I'd like to call on Dr. Kuckerman to say a few words about her role in her very important role in this multidisciplinary team.
Thank you for saying it's a very important role, because it is completely behind the scenes. So I'm here to represent the laboratory research. I'm not a medical oncologist. I'm a research doctor, not a medical doctor. And the people who do the work behind the scenes are sitting right there. So everything that I say here, it's them. I'm here to represent. And so I see the work we do as a link between what happens in the clinic and what later on is developed to bring back to the clinic. So we try to go to what is called the the bedside to the bench, and then from the bench back to the bedside. And so we collaborate with all of these wonderful people to understand the entirety of the disease and make sure that what we do in the lab has a clinical relevance and could make a difference. And I'm happy to say that with these wonderful people that like talking with people behind the scenes, we are able to really make a difference. So every time one of them asks you if it is okay to donate some blood or a little piece of the tissue when you're going through any type of intervention, those types of tissues come to us and Dr. Asasturov, and we really learn from what you are going through, and we are better off in understanding this disease because of that. So I'm very thankful for you as well. Thanks.
And lastly, I'd like to call on Dr. Shannon Lynch to tell us a few words about what she does here.
Sure. Hi, everybody. So I've had the opportunity to work with a lot of the panelists for quite a few years, but this is my first time coming to this event, Together Facing Pancreatic Cancer, and I've had a chance to mingle with some of you, and I just want to thank you for welcoming me, and thank you all for being here, first and foremost. So I'm Shannon Lynch. I'm a population scientist that focuses on health disparities research and cancer prevention and control. So in my research, I focus on how our lab studies how where you live, your neighborhood, environment can work together with your biology to increase cancer risk, and how your environments and biology together, putting that information together, can help us better identify patients who are at higher risk for cancer, and also communities that are at higher risk for cancer who might be in need of interventions related to education or even screening. So that's kind of what I focus on the lab side of things. But I'm also wearing two hats today. So I'm here as a researcher, but I'm also an assistant director for our community outreach and engagement core at Fox Chase. So you might see some of the surveys on the table asking you what you think about cancer research and what you think we should focus on. If you have time to fill those out, that would be great. And then we also have programs available if you're interested in getting involved and helping other families and patients and caregivers who have had pancreatic cancer. I have a couple of brochures about our patient-to-patient network, and if you want to fill out your contact information, we'd be happy to tell you more about the program. So thanks for having me, and I'm happy to answer questions.
Thank you very much. All right, so now is the time where we open it up to you for any questions that you might have. So just to remind you, there should be cards on the table, and you can hand those cards to some of our staffers here who will help bring those up and we can answer them, or you could just stand up and ask questions. It's up to you. And we have a couple microphones out there to make sure that everyone is heard as well. Any questions from anyone? Yeah, please.
Thanks. Is it on? Yeah. First of all, I want to thank everyone for having this forum tonight. It's great. I'm owe my life to Fox Chase, and I'm now a 9-year survivor. And thank you. My question really is to the entire panel, and if you could all put your time machine hats on and tell me where you see the diagnosis and management and treatment of pancreatic cancer in the next 5 to 10 years, how it will change.
Yeah, I think probably each of us is going to have a different answer on that. And that's great. That's why there are so many of us up here. I'm going to start with Dr. Dotan.
I'm actually happy you started with me because I get to choose the easy things. So I think it's a tough question, and I think the way that I would think about it is if I look back 5 years ago, really the amount of understanding that we have of new forms of subtypes of pancreatic cancer have really grown and expanded over the last 5 to 10 years. We've learned to identify subgroups of pancreatic cancer that are genetically oriented. Sorry, I stole your thing. Subgroups that are driven by various mutations within the tumors, subgroups that are more, driven by just where the tumor is located, and maybe the treatment should be different based on the location of the tumor, the location of the metastases, whether the surgery should be different based on where the tumor is. So understanding these subgroups have really led to improvement in outcomes and changes in how we evaluate this disease. So seeing that evolve over the last 5 years, I think the next 5 years will bring us even more understanding, even more treatment options. I mean, we're seeing every few months some new drug being investigated or even approved for these very rare subpopulation that may be 1% of pancreatic cancer, but 1% plus 1%, and that adds up. So I think that would be the biggest change.
I'll just add that I think in terms of the diagnostics, what is already here and will certainly be even more common in the coming 5 years will be particularly blood-based, but perhaps even urine-based or other types of technologies where you can look for very small amounts of tumor DNA, even at the point where tumors of the pancreas or other parts of the body have not even been diagnosed yet, but can be picked up at the subclinical level on a blood test. And so those technologies are very powerful. Again, they're already here. They're multiplying rapidly. I think we're still learning how to use them, but give it 5 more years, we're going to be much better. I think certainly the groups that we know that will know the best as time rolls on. How to use these are, again, back to my core area of interest are those people who have higher hereditary risks because of a particular gene in the family or a family history or maybe even an exposure like smoking history. So I think that we will see those things available to patients in the very soon future.
So maybe from a different point of view, maybe from a different point of view, understanding how the body's natural defense against cancer works is getting more and more attention. We've heard a lot about the immune therapies. Pancreatic cancer is really exceptional in the fact that it really works against our immune system. There is a way for the pancreata to try to fight the immune system from coming in. And right now, behind the scenes, there is a lot of hoopla trying to figure out how to allow our natural defense to enter the pancreas and work as it should. So hopefully in 5 or 10 years, I'm hoping that will be something that is significant. And the other thing is what Dr. Hall mentioned, the more patients we identify earlier with some predispositions, either genetic or exposure type of predispositions, will, if we were to be able to catch this early and learn how to intercept, then hopefully we will have more patients going through it earlier, getting to Dr. Reddy's table on time and being more efficacious.
Say one thing too as well. I think it's going to make next 5 years probably my life harder, and I'll tell you why. I think what we've noticed now is with all these new therapies out there, the fibrosis, which Dr. Kuckerman loves, certainly can make the surgeries more challenging. Again, this is where, at least sort of in my field, learning how to operate in a setting where the tumors are irradiated and all these new techniques that Dr. Meyer is talking about certainly adds another layer of potential complexity to surgeries. And training our next generation of surgeons to be comfortable in that sort of field is one that is going to have to happen. I was fortunate enough, again, Dr. Hoffman has been operating on radiated patients for 35 years, and when I came here to train, that was a skill set that I picked up. So I think as the treatments get better, the tumors get smaller, they become more fibrotic, they shrink, but they also pull in everything around it. And being able to separate that and knowing what's tumor and what's not tumor is going to be a skill that we'll have to sort of continue to learn.
Yeah, this was a good question because we've got lots of different answers from different people. Go ahead.
So just to, is this on? Okay. Just to touch too on the earlier side, so not just diagnosis and treatment, to piggyback on what some of the panelists have said, I do think targeting hereditary cancers, genetic risk assessments is one way that we can help to address the pancreatic cancer burden. And then also expanding that on an even broader level, we do know what some risk factors for pancreatic cancer are, like higher rates of smoking put you at risk for pancreatic cancer, obesity, some diets. So we're learning more about and going along with diet and physical activity, for example, we know that the built environment that you live in impacts your ability to be able to be physically active or to have access to healthy foods. So from a broader standpoint, I think focusing on prevention efforts, addressing things like smoking, obesity, having better environments to support physical activity, those are important, not just for pancreatic cancer, but for health outcomes more broadly, because they're contributing to disease development. So I think that we're starting to see that, and I think if we're on the prevention side, trying to focus on those areas, while at the same time on the treatment side, we're trying to improve treatments, I think together those two things can help us decrease pancreatic cancer that we're seeing now.
Thank you, that's great. All right, so I have a couple questions up here from the audience. So the first one is, I see signs for the Greenberg Pancreatic Cancer Institute. Can you tell us what happens at the Institute? So I'm going to send that one to Dr. Kuckerman.
So the Greenberg Pancreatic Cancer Institute was nucleated by philanthropy. The wonderful Conchetta Greenberg donated a significant amount of money to Fox Chase to encourage what you're seeing here tonight. All of us working together and doing research as a holistic way to look at cancer. And so the Pancreatic Cancer Institute is really that. Is all of us together. We meet regularly. We have a program manager sitting behind Kate over there who really keeps us coordinated. She knows, she's our umbrella and brings together the clinicians and the population scientists and everybody else to try to understand what every modality does so we can work together and communicate that to you the way that we're doing it tonight. So I hope I answered.
I think so, yeah, thank you. The next question, and please, oh yeah, please, go ahead. I'll ask it afterwards, yeah.
Thank you. I'd like to thank the doctors here at Fox Chase. This is the best hospital ever in the world. I know I say that a lot, but I mean it. It's because of you guys that I'm still alive. 5-year pancreatic cancer survivor. Right? I wanted to know, what is the percentage of patients that need mesh implants after a Whipple surgery? Like, I can't be the only one. I'm fighting with this. It's a hard fight, and every time I come to these dinners, I always get questions answered, and then the problems seem to disappear. So I'm thinking, if I pose this one, maybe somebody can help me, because I'm super duper struggling with this mesh and after Whipple.
All right, I'm going to ask Dr. Reddy to comment on that.
Well, so normally after a Whipple would not use mesh in terms of if there's a hernia there. There's a couple types of meshes. Now, I'm not a general surgeon per se, but there's synthetic meshes that sort of incorporate into the body, and there's biological meshes which sort of, dissolve. If there's a synthetic mesh, it could cause irritation, and the things that people can experience with that after a Whipple, if you get a hernia repair, could be scar tissue. And sometimes that can be something that we have to sort of deal with, not necessarily live with, but have to work through. There's things where some people can remove the mesh if that's an issue that becomes something that is chronic. But I think that answers somewhat of the question.
What a percentage?
Of how many people? So in general, again, at the time of a Whipple, I would never put a mesh in. Afterwards, if you develop a hernia, then yes, that can happen. And that probably, overall, hernias after Whipples, I would probably say can be anywhere between 10, 15%, because it's a combination of two things. Your body is sort of beat down from chemotherapy, radiation, then surgery, and then recovery. And hernias can happen after these operations. And when they do, we have to have the decision as to sort of, do you want to repair it? And what sort of mesh is it going to end up being used?
Thank you, Dr. Reddy. Yes, we have a question over here. Yes, sir.
Ready to go?
Hi. My name is Tom Kaufman. I was diagnosed a year ago with stage 4. And 6 months ago, I thought I was at the end. I feel like the picture of health today. Dr. Astaturov has led this team. I'm a realist. It's a serious disease, but I feel fantastic. And again, I thank the team for all that. My question is more towards what can all of you do in interfacing with frontline medical workers, primary care physicians, to make sure that more information is proactively distributed to their populations. For example, now that I've gotten into the history of my family, I've discovered that virtually all of my female relatives have had some form of cancer, almost without exception. So it's easy for the layperson to go, aha, they should have known, or symptoms that presented over a year or 2 or 3. I recognize the challenge. One of the challenges in pancreatic cancer is that the symptoms often are similar to so many other afflictions that are less serious and aren't caught right away. So what can be done to really improve frontline awareness and communication between the work you're all doing and the people in the trenches? Thank you.
Yeah, that's a really good question. I'm going to ask Dr. Hall to comment on that a little bit, and then maybe some others have something to say too.
I was going to ask Dr. Lynch that she might be able to comment better than me. I'll make a quick comment that in addition to research, and I'll let Dr. Lynch talk about that, I think you're right. Even though we've learned an enormous amount about clues within families, whether they be strong family history of breast and ovary cancer or melanoma, or things that may indicate cancer risk for other cancers like pancreatic cancer. Still, when you're out there, in your private practice on Cottman Avenue, seeing patients for blood pressure, and a sore toe, you're not always thinking about pancreatic cancer when someone has lost a few pounds or they developed diabetes at 70. Who hasn't developed diabetes at 70? So I think that part of it is education. There are also some pretty amazing advocacy groups that really make huge efforts. I think one of the most common ones we see in the hereditary space is called FORCE, and they do an enormous effort to get information out to the community, including the community of physicians, to make sure they always have diagnoses like pancreas cancer at the top of their list, because again, rates are going up. This is something that 15, 20, 25 years ago was a rare disease, is becoming a much more common disease, so everyone needs to be thinking about this. Shannon.
That's a really good question, and it's a question that I think about a lot in the type of research that I do. So what we're doing now is we have an Office of Community Outreach here at Fox Chase. So we work with community partners. Through these community partners, they include health centers, and they also include like organizations like churches, for example. So we have an educational resource center where we can send information to community partners and to our health partners to give them information about cancer or pancreatic cancer more specifically. So we make sure that we have those efforts in place. The type of research that I do geospatial analysis. So I try to identify neighborhoods or communities where there are higher rates of cancer. So utilizing that information, what we're trying to do now is actually target partners or providers in those areas to let them know that this is an issue, that there's a higher burden here than maybe other areas. Given that information, we educate them on like risk factors to look for, let them know the resources that we have here at Fox Chase related to like genetic risk assessment, which is like what Mike does. So those are things that we're actively trying to pursue to make sure that we are reaching out to providers where this might be an issue. And another program we have is our Care Connect program. So the health providers that are affiliated with Temple Fox Chase, we're able to reach out to them more specifically. But again, through our community efforts, we're trying to expand beyond just Temple and Fox Chase, work with federally qualified health centers or even community organizations that can help us get the word out.
Thank you, Dr. Lynch. Any question? Thank you for the audience.
Hi there. My name is Perry Shackelford, and my wife Shirley Volker is a 12-year survivor of pancreatic cancer. And we owe it to Dr. Hoffman. And one thing that Shirley always has to say about our situation is, what's this bad attitude?
Oh, yeah. I also had a stroke as a result of having rampant diabetes after the pancreas, after the Whipple. And I'm a firm believer that the biggest disability, even though I lost the use of my left arm, is a bad attitude. And I think that everybody here at Fox Chase has such a positive attitude. And I was sent to another Center City Hospital before to have the Whipple, and then I interviewed down there, and then I came here, and I realized that everybody had this positive attitude, as opposed to the big city hospital that really treated me like I was a customer, not really a patient. So I want to thank you for having such a positive attitude.
And now my question. My question is about the advances that we've seen in robotics up to now and that we may be seeing over the next 5 or 10 years. How do you think that might affect your practices and your procedures?
Yeah, so that's a good question. So we've implemented a lot of minimally invasive surgical techniques in pancreatic surgery. Obviously, the ones that probably is getting the most momentum is for tumors that are more so in the body and tail of the pancreas, where we can go in robotically or even laparoscopically and remove them. For tumors that are more so in the head of the pancreas, there is some gaining momentum in doing these operations robotically as well. Long learning curves, very highly select patients. Problem with pancreatic cancer is that a lot of these tumors are bulky, large. They involve veins, vessels. They're all getting preoperative therapy. So even an open operation is still a challenging pursuit. But there are select cases where minimally invasive techniques have shown benefit.
I say one thing. I always, often when I'm meeting a patient for the first time, I say, one reason you have me to do this job and not a robot is that there are subtleties and nuances to what we do in medical oncology and everyone up here that I think a robot can't do, and that's listening to you as patients on the first day to understand, what are some of your initial concerns related to the disease? What are some of, your short-term and longer-term goals? What, along the treatment journey, as we say, what are side effects that are harder for you and what are ones that aren't? I think that's all part of the relationship that we really have as oncologists and cancer caregivers with our patients, is to be able to listen and hear those concerns and try to tailor what we do to, again, your needs and your values and your goals and what you want to accomplish, and try to achieve those, if not beat those. Anyway, I feel that hopefully I do a better job than a robot, because it's not just about choosing, the right chemotherapy or what's first on the list or second on the list. I just think there's a lot more to it than that, and I think that's part of what makes me proud of the team here that we work with, is I think we all do that in our own way.
Thank you. Actually, that's a different perspective on robots than maybe you thought you were going to get, but I think it's a very good one. I'll give you a third, which is that we use robots every day in radiation oncology. You probably don't think of that either. But we're able to control our treatment machines in more and more precise ways every day. And we're able to do things like have the machine move as patients breathe while they're getting treated, to follow their tumors, and do things like that to minimize treating anything we don't want to give radiation to. So yeah, lots of ways to use robotics. Interesting question, thank you. I have a question here. It says, I was exposed to DES in utero in 1959 and saw research associating this exposure with pancreatic cancer. So the first question is, have you seen this research? And I'll be honest and say I have not seen this research. I don't know if anyone on the panel is aware of this research. Looks like Dr. Lynch may be.
So I actually haven't seen it in pancreas. I've seen it related more so to vaginal cancers. That's typically where it's come from, but it's something that we can look into. Yeah.
What is DES, Shannon? DES still control?
Yeah.
It was a birth.
Is to prevent to miscarriages. Yeah, and actually my grandmother took that. So that's one of the reasons why I'm also aware of the literature.
So the next question here is, I am also a 2-year survivor of triple-negative breast cancer. Is there any screening or prevention I should be aware of? So maybe Dr. Hall can answer that question.
Can you clarify the question? Also, so both pancreas and triple-negative breast cancer? Was that what I understood?
It doesn't actually say, but considering where we are, I think that might be a reasonable.
I just was wanting to make sure I understood.
And I have the abstract of the paper.
Okay.
Oh, wonderful.
But no, I'm a survivor of triple-negative breast cancer, but also DES exposed. And I have the abstract of the paper. If you want to take a picture of it or something.
So I can answer that. So again, the DES question, I think, at least in my knowledge bank, is a little less clear, but the genetics of triple-negative breast cancer are increasingly well known, and there is actually a strong overlap of the genetics of triple-negative breast cancer with pancreas cancer, particularly with the BRCA1 and BRCA2 genes, but there are others as well. I think these days, actually, for both pancreas cancer and triple-negative breast cancer, the national guidelines would say that everyone with those diseases would be eligible for genetic testing. So hopefully that's been offered to you, and if it hasn't, let me know, because we can work on that. If outside of that, if there wasn't a particular genetic risk, I'll just say that depending on if there's other cancers in the family or other potential risk factors, you could be eligible for pancreas screening by some of the protocols and studies that are out there right now, but there's no population-based pancreas screening for the average risk population right now, just so you know. I think that's coming. It will probably be a few years before we get there, but right now it would be under a study of some kind.
Thank you, Dr. I'm going to ask a question to Dr. Estatorov, and maybe Dr. Dotan can comment also about clinical trials that we might see on the horizon. So not what's currently available, but what we think might be coming, let's say in the next, couple years, 5 years, something like that.
I'll leave Efrat most time to answer this question because she's an expert. But as we move forward, what we do is actually we're trying to learn from you as patients to understand better what is the mechanism that drives this cancer in the first place. How can we bring new therapeuticals, new drugs? That's the biggest problem that most patients face, that they run out of options, and by the circumstance, we are forced to become clinical cancer biologists. We're essentially applying knowledge of mechanism to the clinical practice. That's what our specialty is. One of the lessons I actually learned from you, Ira, is that we have to make an effort to make tumor microenvironment of the pancreatic cancer converted from cold to hot. And I think that's is one of the reasons why you did so well, because you also develop autoimmune complications from your treatments. So this is sort of a theme that, there's a number of labs at the center that are thinking that way, and I hope this will bring new opportunities in the future.
So I think this is a very complex question to answer. I think the research in pancreas cancer is moving in multiple directions. And I think aside from the obvious thing of developing new treatment options, developing new biologic targets, testing new drugs, developing different ways to give chemotherapy or to do studies, one big issue that we face in pancreatic cancer, and there's a lot of literature about this, is that there are many barriers for patients to get on studies. And in fact, there are studies out there showing that majority of patients do not make it onto a clinical trial. The percentage of patients that do make it is in the range of 10-15% with the best series that are reported. And that's a huge problem, because even if we have the best studies in the world, if we don't have patients, it's useless. If it takes us so long to complete a trial because we can't put patients on it, there's no point. Sometimes the data is obsolete by the time the study is reported. And a lot of the research now in pancreas cancer is trying to tackle this in addition to thinking about the novel therapies. How do we address barriers? How do we make studies accessible? How do we open them in the community, areas where majority of the patients are being treated? How do we make the study eligibility criteria open enough so there's enrollment and availability for all patients? These are things that are really, really in the forefront of clinical trial development now, aside from all the biologic important factors that we all believe in. And I think that is, I hope that's going to be the biggest change that we'll see coming in the future, that all of these modalities will be available for more patients, and we will be able to move the field forward faster because we'll be able to accrue patients to trials and ensure that we get the data in a timely manner.
I wanted to just make one other comment, that there also are increasing trials that are looking at some of the, I guess, diverse impacts that pancreas cancer can have on a patient and on their functioning. And we most recently had, I thought, a very interesting and cutting-edge study open that was looking at a factor that was meant to help alleviate cancer cachexia, so the ability of a tumor, which is particularly common in pancreas cancer, to basically, make a patient not want to eat and lose enormous amounts of weight. And this is a classic ramification of this disease. And this a company was particularly interested in developing an agent that would potentially fight against this. We actually had enormously great accrual on that study at our institution, and one of our docs, who unfortunately has subsequently left, presented that data at a national meeting. And I think the data were pretty exciting. In my own practice, I had some patients who did quite well. And so I think there's sort of, as Dr. Dotan indicated, multiple branches of how this research is going, and I think that's one of them that's exciting. I'll make one other quick plug for one of the colleagues of Dr. Lynch and me, who, in the same vein as what I just spoke, looked at using a low impact exercise intervention while patients were getting treated for pancreas cancer, to see if that low impact exercise intervention could improve their tolerance of chemotherapy side effects, improve some well-being endpoints, but also look at just overall how people do. Did they live longer? And although this was pilot work, we presented those data at a study at a conference. I think it's been a couple years now, but the data were actually pretty impressively exciting. So sometimes, even though we all love our fancy drugs and our fancy tools and our robots, sometimes the simpler things can actually also be really impactful.
Thanks, Dr. Hall. I actually have another point and plug too. So related to the barriers to participating in trials that Dr. Dotan touched on, some of those barriers relate to social determinants of health. And can we get access to transportation? Can we come to the clinic as frequently as we need to? That's something where we can work together with our colleagues in social work to make sure that those pieces are put together. And I just also wanted to mention that in our Office of Community Outreach, we do have this program that we're trying to relaunch, our ambassador program, which is an opportunity for any of the patients in the audience who have participated in medical research, in clinical trials, who would like to talk to other patients about their experience. We are looking for ambassadors, because one of the barriers to participation in trials is that people don't know about them and they may be apprehensive. So hearing from you is really helpful. So if that's something that you think you have time for or you're interested in, please come and see me, because we're looking for ambassadors. It would involve a training program, about a 7-week training program, and then you would go out into the community and you would talk to people in the community and then also other patients about your experience. So come and talk to me if you're interested in that.
Thanks very much, Dr. Lynch. That's great. I think I'd like to move on to this question, which was submitted by an audience member, which says, I'm a 20-year survivor, so I think we should applaud for that. How much of a difference is there now versus 2 decades ago in the survival rate? So maybe Dr. Reddy could comment on that.
So I always tell people, never look at the numbers, because when you look at the numbers, the first thing you look at is sort of the overall trends, and it can be difficult pill to swallow. When you look at the numbers, we are now approaching double digits, right? And that still sounds, not great, but it's that, remember I said in the beginning, that small incremental moves that needle makes is what it's doing now. And I think that we are making progress, and I think it's through efforts like we just talked about across the complete spectrum, not just chemo, radiation, drug development, but being more proactive as opposed to reactive, right? Understanding the population sciences of it, understanding environmental risk factors, personal risk factors. So I think that because of that, that's why the needle is moving. So my hope is that in the next 5-10 years, it moves even more, because we're focusing not just on one thing, but sort of the culmination of everything.
So when I started doing research, between then and today, just focusing on pancreatic cancer, the 5-year survival for patients with pancreatic cancer has doubled. And so I'm not that old, and so I think that it is pretty amazing how fast, despite of the fact that we still have a long way to go, how different it is today than it was 10 years ago.
So I think we have a pretty young panel here. I don't know, most of us were not in practice 20 years ago. But I just want to talk about what happened in the last decade. And when I was a fellow here, we pretty much had one drug for pancreatic cancer, and it was awful. And now we have 5 approved chemotherapy, and more if we think about these subpopulations, and it's only been a decade. So it's really, really exciting to work in a field where constantly things are changing and moving, and there is, 10 years is not such a long time for your practice to completely change and have multiple options. So, we're still have a long way to go, but I think, we've done pretty amazing things in 10 years.
I think we've also learned the, our old approach was develop these very powerful drugs that sort of, like the gemcitabines of 20 years ago. They suppressed what we knew about cancers is the DNA multiplied quickly in the cells, divided quickly, so we developed drugs that slowed that process down. And what we found in some cancers, it could cure some cancers. Other challenging tumors like pancreas cancer, it could slow cancers down for a while, but not too long. I think we have become more sophisticated, and we've learned that there actually are, in many tumor types, actually even more potent, not necessarily always that common, but more potent targets, that if we can identify those potent targets, they can actually beat out some of the old chemotherapies we developed by 2 to 3-fold. And so I think now the challenge of the late 2010s, 2020s is trying to identify more and more of those potent targets that make patient X's tumor different than patient Y's, different than patient Z's, and making sure we have all of those correct drugs there to hit those combinations of targets. And I think it's with that kind of thinking that I think we've accelerated the field more quickly in the most recent years, and I think that we'll go even farther as we do better with that.
I may just add one thing, that besides the progress, pancreatic cancer still remains a national urgency because the rise in incidence is alarming. Pancreatic cancer is one of the few cancers in the Western world that is on the rise. And it's roughly by 0.12% each year. We don't understand why it is the case. And this is very disturbing. I think we should also kind of take it on ourselves to go and fight for increased funding for pancreatic cancer research. We have to take on ourselves to bring more patients to clinical trials, and just look at the list of participants. It's incredibly genetically rich. Caris, Exact Science, Foundation Medicine, Gordon, Natera, Tempus. Almost every patient who we see has been tested genetically both on the tumor and on the germline blood DNA. But yet, we still don't know much about what causes it. So this is a disturbing trend, and we should not lower our guards, but rather be more proactive and advocate for more funding and more effort in understanding the mechanism of this tumor.
Thank you. So I'd like to address a question to Jalen. The question is there a link between nutrition and pancreatic cancer? It's a little bit of a different question than you probably get from most pancreatic cancer patients, but maybe it comes up when you talk to them, I'm not sure.
That is a good question. Not that I know of, is there one specific nutrient that has been known to cause pancreatic cancer? I think, as Dr. Lynch mentioned, there's a lot of different genetic and environmental factors that do come into play, but there are also some lifestyle factors, such as, obesity, that could somewhat play a role. So but as far as specific foods to avoid, that's actually something here at Fox Chase that our dietitians are very much against, is fad dieting. Red meat and pancreatic cancer, I'm not familiar with. Was it? Okay. I'm more familiar with the research on red meat and colon cancer. I'm not specifically certain if that has a link between pancreatic. But I do know there are a lot of myths and fads out there. A lot of patients, as Dr. Hall mentioned, with pancreatic cancer do suffer from weight loss. So our goal as dietitians is to really just help patients to maintain their weight and follow the least restrictive diet possible. Because there is a lot of information out there that, could be detrimental if you follow a diet that is too restrictive. So I guess I'm not sure if I answered that as best as you wanted me to, but.
No, that's great, thank you. Question, does Fox Chase have a support group for pancreatic cancer patients and their families? And another question sort of related to that, what do you suggest when your care is overwhelming? Obviously, these are going to you, Angela.
So we do have a GI cancer support group. It's not specific for pancreatic cancer, but it's open to anybody with any type of GI cancer. And that support group is for patients and family members. Anybody's welcome to attend. It is on our website if you'd like to have some more information. Right now we're doing it as a Zoom format just to make it as accessible to everyone as possible. And I'm sorry, the other part of that question.
Oh, I guess the question is really, what do you suggest when pancreatic cancer becomes overwhelming, or cancer care, cancer, journey gets overwhelming for patients?
So my number one suggestion, and I will admit that I am biased when I say this, is that I encourage everyone to reach out to a social worker, even if you're not sure what it is you're looking for. Sometimes just making that initial call and saying, I don't really know what I'm asking for, but I just need somebody who might understand, who might be able to offer a supportive ear, and even just maybe help me think of questions I might not be thinking of right now is a good place to start, because we do recognize that cancer in general is overwhelming. When you think about pancreatic cancer, and you've heard what all these experts have said in terms of how far we've come, we still have a long way to go. My hope is that someday we're focusing more on survivorship issues related to pancreatic cancer as opposed to all of these things that we're trying to figure out now. But I guess what I'd like to say is that, reach out. Even if you're not sure what you're looking for, just call and say, hey, I could really use a helpful person to listen and just maybe offer some support.
There is a patient-to-patient network, because I'm part of it. There was a training course that I went through a few years ago, and I'm sure there may be other people in here, but I've been connected with other pancreatic cancer patients. It doesn't happen very often. It might happen once a year, but they try to match you up personally with someone with similar circumstances. So, and I've done that probably here a half a dozen times, but I've also done it with patients of other hospitals and stuff that people, friends who know friends that have pancreatic cancer, and they call me and they say, hey, would you mind talking to somebody, which I never have a problem with, but they do have that here. And I'm not sure if that's what you were referring to in the network or something else.
Thank you for bringing that up, because I was going to bring that up. So thank you for that. There are brochures on your table that have a blue heading on it. That's for new patients. You can contact our center, get in touch with someone like this gentleman here who is part of our patient-to-patient network that can help you and your family navigate the process if it becomes overwhelming. And we're also looking for more volunteers in pancreas cancer. So I've talked to some of you about that. That is the brochure with the red writing that says survivors and caregivers. If you think this is something you'd be interested in, if you can fill out the back of this form and hand it to me, we can have someone contact you and give you more information. It's a really helpful program. Thank you. And thank you for participating. We appreciate you.
Yeah, thank you very much.
Does anybody on the panel see a role for artificial intelligence with crunching clinical studies and even at the bench? I mean, at the bench, you can control most of your variables, but when you go to your clinical studies, you're all over the board. Do you see a role, anybody?
So, I mean, I can say we use artificial intelligence all the time, and we're using it much more, actually, in radiation oncology these days, to take processes that, I'm looking at Dr. Hoffman, used to take us quite a long time. He would call me up and say, I need you to see this patient today, I need you to treat them tomorrow. And I was able to see them today, but I wasn't able to treat them tomorrow. Well, we're getting a lot closer. We can basically do that, bring a patient in, and make sure that the plan conforms to exactly the way they look on that particular day at that particular time. So that's done with artificial intelligence because people aren't fast enough to do it that quickly. But please, Dr. Krummer.
So in the research side, there is a big effort that we're participating, but it's driven mostly by MD Anderson, and we're collaborating with them, where we are getting to digitalize pathology so we can use it as a machine learning tool to better not just diagnose, but predict outcomes or efficacy in interventions and so forth. And right now what we're trying to do is learn how to better implement that. So during clinical trials that go on at Fox Chase, where we have access to what was the outcome of the patient and how the patient reacted to the intervention, where we can actually look at the pathological and other symptoms, biological tests, blood, and everything that we can learn from the patient, to put all of that together with the digitalized pathology and come up with better ways to understand the biology and predict how to treat prospectively as well.
Yeah, and then also on the risk prediction, like prevention, early detection side of things, some work that we've been trying to do in my lab is we find these data sources that include like neighborhood data plus clinical data, demographic data, biology, genetics, and we combine it all together and we run machine learning algorithms to see if it can identify patterns in the data that can better predict who's at highest risk of pancreatic cancer. So we're applying it not just on like the treatment side of things, but also trying to use it for prevention purposes too. It's an emerging field.
There are similar studies in genomics where you can sequence large numbers of individuals, look for lots of different heterogeneous genetic markers in the genome, and then link all of those markers to a particular outcome like development of pancreas cancer. So you can develop something which is commonly these days known as a polygenic risk score to understand how all of those 1,000 points of SNPs in a genome actually seem to cluster with development of a particular disease like pancreas cancer. And then you can take those data and then take them out to the general population and say, okay, now I have, the 3 million people in Philadelphia. I can genotype all those people and see who's has the highest number of those risk markers and who has the lowest number. You can use that information to potentially choose who you want to offer screening to. There's also been some really elegant studies showing that, let's say you stratify people based on those polygenic risk scores. Then you can also look at how things like environmental factors like stopping smoking or giving up drinking or exercising more can modulate risk within that polygenic risk. And the differences are actually pretty outstanding. We all sort of think that, whatever genes I got, that's just going to kind of drive my destiny. But it's actually not true. You actually see that the people who have similar risk scores, those that, exercise and eat more vegetables, they actually have better outcomes and have better risks. So they're and again, it's not a perfect science at this point, but I think that the future is very bright in our understanding of how genetics and risk co-segregate.
So I just wanted to add that, everything you've heard so far talks about, really taking huge amount of data and analyzing it, and that can be done now because of all the machine learning and artificial intelligence. And we are seeing that applied in oncology where, it's very, very hard, as I said, to get a study and to get patients. But now that everybody has electronic medical records, we can abstract huge amount of data. We can get data on drugs after they're approved, understand what really happens, what are the real outcomes. There are initiatives to use this data to sort of do a pseudo-clinical trial on data that you obtain from patients from the community. And it's really, the resource is just phenomenal because you can analyze it in so many different ways, looking at so many different outcomes that you'll never have the funding or the options to do in a true clinical trial.
Efrat, maybe you can comment on your recent discovery that taking losartan and vitamin D is beneficial.
Yeah, so this is one example. We have a study here using vitamin D and losartan. And this is a small pilot study that we're testing in a very small group of patients. But we decided to open our own database and see if we're seeing any trends in our own patients, because a lot of our patients take vitamin D because their primary doctors told them to take it, and take losartan for high blood pressure. So we did this analysis on our database, close to 600 patients, I believe, and we were able to show that there was a difference in the outcome. So now we're going to take this data and we want to try and analyze it in a huge national database that has thousands and thousands of patients. So it's not just our little cohort at Fox Chase, and really understand if this is just a fluke that we're seeing here. Is this really a trend? Should this be something that we should explore even further? And then taking those data with what we'll find in our preliminary pilot study that looks at the biologic endpoint, putting all that together can really help us understand how these drugs work.
By the way, this database that Efrat was referring to was created by her, Shannon Lynch, and Nina Vijavirji. It's a great work. Thank you.
Yeah, that was a great example, actually. I think we have time for one last question in the back.
No, but we can hear you.
All right, so 2.5-year cancer, so pancreatic cancer is a lot of. My question is, how there's tests for breast cancer, prostate cancer, colon cancer. That's pretty common. Insurance companies pay for it, but there's no test for pancreatic cancer to get early detections. And I was told I was walking around with my tumor for about 10 years before I accidentally found it. So insurance companies usually, they run everything basically. They do put a lot of input on what happens. So what do you think about?
So why don't we have screening for pancreatic cancer and
where? Because nobody knows, right?
Are we going to get there?
Yeah.
Yes, that's a good question. Dr. Cooperman has an answer.
No, I don't have an answer, but I can tell you that there is a big effort to try and find some type of systemic test that we can test in blood. There are some groups that have some encouraging data, but it is too preliminary. The problem with this is two-side, and perhaps Dr. Hall will help me with this. When we detect this early, there is a difference. So if the test will not be high enough percentage, then there is so many individuals that may have irritation of their pancreas that would look like if there was pancreatic cancer, or many other things within the pancreas that may or may not develop, despite of the fact that it is risky. The aggravation of that and the lack of being able to actually, going through a surgery like what Dr. Reddy does is not nothing. If it were for a test where we're not 100% sure, we would be putting the patient through perhaps a surgery that may have not be needed. So we need, as researchers, to make sure that we have really, truly close to 100% certainty that this is not something, that it is something like pancreatic cancer and not something else, so we can reach out. And those types of predicaments are probably more commonly seen in the risk clinic with Dr. Hall.
Part of the power of a screening test comes from how common the disease is in the population. And one of the still challenges of pancreas, even though a number of us have said tonight that it's increasing in the population, is that compared to something like breast cancer or prostate cancer or colon cancer, which all have over or close to 200,000 plus cases a year in this country and millions worldwide, pancreas is still substantially rarer than that. So trying to develop a screening test that is appropriate on a population level that's detecting a much rarer disease is part of the challenge. The other thing that I think everyone has to always understand is challenging about the pancreas is where it's located in the body. It's sort of, tucked in one of the toughest places to reach in the body in terms of imaging and screening. I often say to my patients, another challenge is there's no lumpectomy of the pancreas, right? If you screen and you find something, you also then have to have a plan in place of what you're going to do at that point. And although I know my friend Dr. Reddy loves to operate, he likes to operate when he knows there is definitely cancer there. He doesn't want to operate and take a pancreas out that there's not cancer in. And so there are a number of challenges in terms of screening, identifying people who have risky lesions, how to take them out successfully, and be sure that we're actually going through all of that on someone who actually has a cancer.
A lot of patients will ask, why don't I just get a CAT scan every year when I turn 50? And this idea of incidentalomas, right? So you get a CAT scan, it opens up Pandora's box, and then you find this and you find that. And then the question is, what do you do about it? So I see a lot of patients with pancreatic cysts, which by and large are benign, but they do need attention. But you can't just scoop out the cysts. You have to do a formal resection, whether it be a Whipple or a distal pancreatectomy. So not trivial operations. So then you take it out, it's benign, complication, and that sort of opens up sort of that whole sort of box. So just getting a scan showing a mass can sort of have some bad effects. So yes, we have to have more targeted sort of screening algorithms to sort of see who will develop that. Now in the cyst world, they're sampling the cysts and they're checking for mutations and trying to see who has high-risk cysts versus low-risk cysts. So the work is being done. It's just sort of not developed to the point where we're comfortable saying that we can do this one test to say, yes, you're going to get it, or no, you're not.
I'll make a quick plug that one of our colleagues who is not here tonight is actually leading a national, nationally funded by the National Cancer Institute, and a national trial looking exactly at this issue related to cysts and how to best manage them that Dr. Reddy was talking about. So for a little cancer center, we're pretty mighty that this was developed and is led here at Fox Chase by Dr. David Weinberg.
Yeah, thanks. That's actually a very complicated question. You've got some really good answers. So this was a great session. Thanks everyone for coming. It was really wonderful. It's the best one that I can remember.